capillaries. This is the hair follicle here, and this is the hair papillae, which is what? Where the hair cells are meeting to push their way up to become a hair follicle, right? What's attached to a hair cell? Name the two items that are attached to it.
Oil gland.
What's the technical name for it? Sebaceous gland, which produces oil. Oil does what for us? Lubricates the hair follicle, but also adds lubrication to our skin and protection, right? What else is attached to a hair?
Sweat gland.
There's a sweat gland next to it, but what else is attached to it that makes the hair stand up when you're scared? Erector. Okay. What are your sensors for touch located in your skin? The Meissner corpuscle, which is which one?
Light touch.
Light touch. And then the other one is? Passimian corpuscle. Very good. What's the difference between the Eucin sweat glands and the what is the other one? Okay, what's the Eucin sweat glands for? Did we mention that yet? Okay, well, we'll mention that today. We know the epidermis is composed of what? Stratified squamous epithelium, and it consists of 4 distinct types of cells and 4 to 5 layers. Where is it 5 layers? On our palms and the soles of our feet. Some of you are looking like you didn't hear this yesterday. We did say this yesterday, so keep up with your book by underlining and keep up with writing, because if you can't recall this right now, then you really need to keep up with your book and reinforce everything by reading when you get home. Okay, the cell types that are in the epidermis include keratinocytes, melanocytes, Merkel cells, which are our sense cells, and Langerhans cells, which are our immune cells. Where else do we have cells that are called Langerhans cells? In our pancreas, right? Islets of Langerhans, right? Okay, the outer portion of the skin is exposed to the external environment and functions in the protection. We said that already. The keratinocytes, they produce a fibrous protein called keratin. We talked about that yesterday. The melanocytes produce a brown pigment called melanin. We talked about that. Why are some people more brown or get more brown than others? More melanin. Langerhans cells are epidermal macrophages that help activate the immune system. So what are they? Epidermal what? What's a macrophage?
Ones that ingest other cells.
It's a big, huge cell in our immune system that goes along the surface here and is looking for things that are harmful to you or that don't belong there and engulfs them. Okay, the Merkel cells function as touch receptors in association with sensory nerve. The layers of the skin, we have thick and thin layers, correct? We're just talking about what we talked about yesterday. The thick skin has 5 layers. It's in our palms and our soles of our feet. The thin skin has 4 layers, and it's covering the rest of our body, correct? Let's name the 5 layers, and let's actually give you the mnemonic or the memory device for remembering the 5 layers of the skin. So do you know what a mnemonic is? A mnemonic is a set of letters that you put down to try and remember things. So you use the first letters usually of the word to do it, okay? So if I say to you guys, A, D, P, I, E, what do you think of? Huh? If I say, it's a mnemonic. If I say ADPIE, what do you think of? ADPI. What am I talking about as I'm doing this? Okay, so this is a form of a mnemonic, okay? So now we're gonna learn a mnemonic about the skin. And so the mnemonic for the skin is B, S, G, L, and C. And these are the layers of the skin. There's 5 layers in the deep superficial area. So the B layer is the and here's where the B comes from. The S layer, same front letter, stratum, spinosum. The G layer is stratum, granulosum. The L letter is stratum, L-U-C-I-D-U-M, which means lacking in thin skin. And the C layer stands for stratum. Anybody know?
Corneum.
Corneum. Very good. These are the 5 layers which are deep in the superficial area of our dermis. And each layer represents a process that has to do with how our skin is actually finally created. Okay? So the basal, it's the deepest epidermal layer firmly attached to the dermis. So this basal is attached to dermis. And it's the deepest. It consists of single rows of young keratinocytes. Young keratinocytes. Young keratinocytes. So what do we think are keratinocytes? Keratin. Keratin is waterproof, but it's the cell that makes what? It makes our skin eventually. It makes our hair, right? Our nails. And the cells undergo rapid division, hence the alternate name stratum germatavium. Remember what I said? If you can remember stratum germinate. What did I say happens in germatavium? If you germinate, what's happening? You're forming more and more and more cells. So this one is also known as the stratum germatavium. So this is what? This is the area that's making all our keratinocytes to become skin. So this is what it looks like where it's at. So if you see this picture, here's the stratum basal. Basal, right here, this little tiny area right across here. Everybody see it? Right across here. And you can see it's attached to the dermis. So can you see what order we're going in for this? We're going from the deepest to the more top surface. Very good. So let's look at the next layer. The stratum spinosa. And we call it the stratum spinosum because it's also called prickle cells. Prickle. This is also named as prickle cells. And it's called prickle cells because it's a filament stick out of the cells as they shrivel and then become the layer that appears spiny. So these layers are starting to change because they're the next layer, right? So we're working toward the top of the epidermis. And then this would be the epidermis here. So this is the prickly cells, and what's happened is these keratinocytes have all come down to these, and they've met with these prickly cells that are joining the keratinocytes together, and they're kind of, what do you call it, spinny looking when they're done. And they have melanin granulars, or the skin pigment, and Langerhans cells are abundant in this area. Why do you think that the infectious preventers are abundant in this area? Langerhans, how do you spell it again? If you're not sure what I'm saying, I hope you're taking notes and looking at your book.
What page is the book?
This is in your book, beginning in the beginning chapter. So in this area where we're starting to really produce the top surface of our skin, right? The cells for the top surface, there's a bunch of macrophage type cells that are fighting infection. Because what would happen if we got an infection in that area?
Unless it goes that direction.
We would then develop cellulitis, right? Because it's a cellular infection. This is where the cellulitis comes from. And you can see that if you get cellulitis in this level, and it goes through all these levels, you can see why it's so serious when a person has it, right? Because it's going through all these cellular levels to become this top surface reddened weeping area. And it's very serious when a person has cellulitis. So there's infection prevention plus melanin. And melanin is getting ready to cling to these spiny cells and keratin and come down to the stratum granulosum. The stratum granulosum is a very thin layer, very thin. And in it, it has 3 to 5 cells that go through drastic changes. It's where the keratinocytes appearance occurs to change. The cells become flattened, and their nuclei and organelles begin to accumulate. So this is where these keratinocytes that look kind of like this, circular with their nucleus, they begin to join with the other cells. So now they look like this, joining with the other cells to become what? A surface layer, right? An epidermis layer. So the cells can't remain circular, so they've got to flatten themselves out and keep piling on each other. And then the keratinocytes have 2 types of granules in them. What are granules? Do you remember from your term 1 about anatomy and physiology, about cell structure? So the granulars are the keratin hyaline cells. You can see those in your book too. And the laminated cells. And those are just things that help adhere these flattened cells more and more together. Adhere means hold them together. So they're very busy working from structure to structure in cell type, but it's the same cells being manipulated to become our top surface of our skin. The next layer is the stratum lucidum, which is a thick skin, and it only appears in the thick skin areas. So the stratum lucidum is lacking thin skin, and where would we only find it? On our palms and our feet. You won't find that cellular membrane layer in the rest of your skin layers. It's only on the palms of your feet and, the soles of your feet and the palms of your hand. Okay, guys? And it consists of a few rows of flat dead keratinocytes, and they just keep pounding together until they make the epidermis structure. They're present only in the thick skin, which is our heel, our plantar, oh, thank you. Oh, you can't see it? I'm sorry.
Because it has a bad reflection, and when it's real light, it's like you
I'm
can't
sorry,
see it from the
guys.
back.
Thank you. It's only present in our heel, our plantar, and our palmar surfaces, which is our palms. So what area has the stratum lucidum? The palms of our hands and the soles of our feet, okay? The next layer is the stratum corneum, and we call it the horn-like layer. And that's this one here. So you can see these letters now. This is the L, this is the C, G, S, and B. Even if you can't remember them, if you write these letters down and there's a question about, it says something about the innermost layer of the skin or the deepest part of the skin, you can write these letters down and know that the stratum basal is the deepest. And that's where the cells are just beginning, right? For your skin surface, correct? And there's a lot of keratinocytes there, and there's a lot of action going on as these cells are working on becoming the next area, which is the stratum spinosum, which is also called the prickly cells, because they make the keratinocytes stick together. And it kind of ends up looking like a spinny swirl of cells joining themselves. And then in between there and the stratum granulosum is the Langerhans and the melanin, and the Langerhans are preventing infection while the melanin are building up to cause pigmentation. So the more melanin you have in that level that pushes its way to the surface, the darker you become, okay? And then the stratum luteum is only in where? Your palms and your feet, so it's only in the 5-layer system, right? And then the stratum corneum is the horn-like, and it's the top surface finally where everything hooks together and pushes its way, becomes very water resistant. It develops pores for the hairs. All of that stuff are all there, and it secretes sweat and oil for protection and cooling. It allows for cooling, protection from outside microorganisms, protection from other infections, as long as it's not cut or bruised or scraped, right? So you guys know that. Now let's see about our next slide here on our handout that was talking about all this. So we talked about all this just now, did we not? Okay. I was hoping you didn't see this pop-up that just popped up. And so when it says like this, the outer layer of the skin, so what layer are they talking about? The epidermis or the
Corneum.
corneum. Very good, you guys. So now you know how to list those. The structures of the skin, we talked about the dermis being the true skin. It contains blood vessels, nerves, oil glands, sweat glands, and hair follicles. And its subcutaneous level layer connects the skin to the muscles, and it's composed of what? Adipose and loose connective tissue, but has no vasculature to it, okay? And then here's that wonderful picture of the skin. And we've talked about a lot of these things already, so let's move on. The appendages of the skin, we have the sudoriferous glands, which are the sweat glands. We have the craniumous glands, which are located in our ears to make ear wax. And we have the sebaceous glands, which are oil glands, and they secrete sebum, which is that milky white substance. And the reason why it's milky white is because it's predominantly your white blood cells fighting off whatever, in fact, a virus or bacteria got there. And then you have your hair, and it's composed of a modified layer of epidermal tissue, mainly keratin. And so is your hair at the end right here alive? No. Did you know that if a work wants to prove you lying on trying drugs or using drugs, and maybe you keep showing up clean but they had caught you once, they can get a court order to cut your hair? And even if you've had your hair cut because you heard through the grapevine that this was going to happen and then you had your hair dyed, even with that, they can predict or see 10 years of history of any drug use or any chemicals you've used on your hair by looking at your hair. So it doesn't help to cut it really short. They can still see 10 years of what is in that hair. Your hair tells your history, you guys. Nails are composed mainly of what? Keratin, right? How many sweat glands do you think we have in our body? We have about 3 million. Who sat there and counted them? And the sweat that we sweat out, what's it composed of?
Salt.
Water, salt, urea, uric acid, ammonia, sugar, lactic acid, and ascorbic acid. So let me ask you this. Our salt can tell us, our sweat can tell us what diseases we have. Did you know that? When a person is in complete kidney failure and their body cannot get rid of any of the waste and they've not had dialysis yet, when they sweat urea, which is a component of urine, and it looks like little tiny microscopic drops of urine, solid drops of urine all over the entire body. So that's a kidney failure person who's not had any dialysis yet. They sweat a component of the urine because the body has to get rid of that waste. Another thing we can see with sweat is we know whether or not you are secreting too much sweat, right? What's the difference between normal sweat and diaphoresis, for example? When we say someone has diaphoresis, what has happened? Why is that sweat so different? It's a lot of sweat, but it's stimulated by our parasympathetic system, which is the old, if you believe prehistoric times, it's our old responder for if the lion was chasing us, our parasympathetic system would kick in and help us get away from the lion, right? It would give us the fight or flight response that we need. Well, in the parasympathetic system, when it kicks in, your body, your heart, when it's hurting and breaking down, having a heart attack, it sends messages chemically to the parasympathetic system. And so these patients sweat from areas they've never sweat from. And you lift them up to take their blood pressure, and the sheet will be sopping wet all over it, all over their back. I mean, these people, you dry them off and they're wet still. So it's a very weird phenomenon that happens with the heart releasing cells that go directly to the parasympathetic system and send out a message that the body's in crisis. And it starts the body profusely sweating, or we call it diaphoresis. Okay, so inspection and palpitation, we talked about that yesterday. You want to ask the patient what? What's one question you wanted to ask the patient? And it's right behind me, so don't guess.
I'm sorry, I didn't hear the question.
You're assessing the patient's skin. Ask the patient what?
Where the lesion first appeared.
If they've had recent lesions and where it first appeared. Very good. And next, what other question would we ask?
How long have you had them? Have they gotten bigger? Have they gotten worse?
Did you eat anything that triggered them? Very good. So you're staying on the lesion still. That's good. So you've gotten the whole lesion information now, right? So now what's the next question?
Recent skin color changes?
Any recent skin color changes? Because that tells us how the thyroid's functioning. If the thyroid or hypothalamus start going wacko, you can have things like vitiligo, dry skin, skin color changes that are unexplainable. You get these different kinds of growth on your skin depending on the organ system failing. What's another question you can ask?
How much exposure did you have to the sun?
How much exposure did you have to the sun, and what would you add to that?
Yeah, tanning boots.
Did you go to tanning booths? Did you use any suntan oils or anything at that time? Did you think about sunblock at all, right? Because we want to reward them for everything they say, right? And so, what's our very next question we'd ask them? Family history of skin cancer. How important is that? It is very important. Unfortunately, we inherit all kinds of things from our family, right? Whether we want it or not, we get it. And another thing that you would want to know is you're observing the skin color generally, but you're assessing for lesions they don't tell you about. Okay, so they might say, no, I don't have anything. And as you look, you find these. So during your inspection and palpation, you're inspecting the skin for all of these things, and you're feeling it as well. And the only way you can really feel skin is with a bare hand. However, if the person is diaphoretic, or the person has a lot of secretions, bed sores, and you know they're dressed, maybe their sheet's not that clean, so keep gloves on if you have to. The only problem is you can't interpret actual skin temperature with your gloves on. I've been known to move my glove like this a little bit on my wrist and put my wrist like you're feeling water down on the patient's skin to see if the skin feels warmer than usual. You have to be careful if the patient has scabies. You don't want to expose any piece of your skin to that person because scabies is caught skin to skin contact. They don't jump, they don't fly, it's skin to skin contact. Okay, so we move on now. And we talked about dark skin, how to assess dark skin, and what did we say was one of the key areas of assessment? The gums, right? The bucco, the cheek area, very good. What's another key area? Conjunctiva, very, very good. And then what's another good area? Another good area to assess our skin on our darker skin patient is to look at their palms of their hands and their feet, because you've looked at their bucco, right? And you've looked at their conjunctiva, and it's looking kind of strange, kind of yellowish. So if you move into the hands and they look yellow too, then that jaundice is really bad. It's probably Hep B. If their palms don't look like they're yellow, just their conjunctiva, it might be just starting, and you'll catch it. As far as reporting it, you'll catch it, not catch it from the patient, but you're be able to say slight yellowness noted to conjunctiva of eyes reported to MD, because it wasn't told to you before. Rashes can be difficult to detect, especially again if you're wearing gloves. So you've really got to use your sense of sight and your feeling of gloves, different texture changes. Gloves that we use now are nitrate. Most hospitals have gone to them because of lawsuits for latex allergies is just off the record, and so they have all changed to nitrate type gloves. So they're a little bit tighter feeling, they're more smooth, they have no rubber powder inside them, but physicians and nurses complain that they don't feel the things they want to feel with those on, because they already apply a slight pressure to our skin, so the only receptors left to respond are our precocium, which are deep, and we don't want to push on somebody deep to feel something. We want to feel light touch, because that's sometimes where you identify a lump, in the light touch. These were some of the primary lesions we talked about, the primary words for these lesions, and we also talked about how they affected a person when they had this type of lesion. We went from there to the assessment of skin, and we used a certain method called the PQRST. Easy to remember because that sounds like a cardiac rhythm strip, right? And the P stands for what provokes. What are the factors that provoke it or bring it to calmness? Okay, so P, you want your patient to, when you see the lesion or you see the skin has a bad rash, you say to them first, P, provoke. What provoked this rash? What's provoked? What brought it on? What made it worse? I don't know, I bought new detergent for my clothes and then I got the rash. Aha! What caused it? new detergent. Sometimes it's not that obvious, right? And then the Q is the quality or quantity. So is this rash from head to toe, or is it just in a local area, okay? And then in that local area, is it overcrowding the local area, or is it scantly in that local area, right? Do you know what that means, overcrowding and scantly, everybody? Is it in this little nipple area above the nipple and it's just so much that you can't even see the skin because it's all involved in the rash? Or is it above the nipple but you can see the skin still and it's just scanty red marks there? Okay, so you have to determine the quality and quantity. The region would be where? Where is it? The nipple area or wherever you found it. Severity of the signs and symptoms. That's what the patient tells you. Oh my God, I'm up all night long scratching right here and I'm afraid I'm going to tear my own skin off. Okay, well, what symptoms are there? Well, it's been itching and burning. It gets worse when it's hot. I have to go home and change my shirt. I put another, and you're getting this information from the patient. Time the patient has had the disorder. How long has it been since you changed your laundry detergent and developed this rash above your right nipple? Oh, about 2 months now. Sometimes you get 6 months to a year response, and you're thinking, why now? Why did you come in now then? Why couldn't you just make an appointment, see your physician and get it fixed, right? We always think that way when people say they've had something for a year, 2 years. I had a guy come in with a sore elbow for 10 years and he wanted Kaiser to turn on their MRI machine right there at 3 a.m., do an MRI and call an elbow surgeon because he was tired of having elbow pain. Well, we can understand being exhausted, but if you looked at his record, he had not bothered us for all those 10 years until that night. So you're like, what happened that all of a sudden this elbow pain hurts him, right? Okay, so the identification, assessment of the skin, identification of potential malignancies. When we say potential malignancies, what are we talking about? Cancer is what? Moles. And so when they use these words, asymmetry, it would mean that you would see a mole asymmetric. So let's say it starts off, oh, you want the black. So let's say it starts off round over here and it starts coming up, but over here it goes like that. So that's asymmetric. Okay, it's not the same all the way around. And then the other term, borders are irregular. Same kind of idea, but the irregularity comes like this. And then maybe over here it goes like this. Anything that does not have a good circle to it is considered asymmetrical or borders are irregular. The color, is it even or uneven? Is the mole completely black all throughout all of here? Or light brown? And then right here it turns to a pink or darker than the rest? I can't even make it look that way. This would be the area in question, but that's not just the area they would remove. They would remove the whole mole. And when they do mole surgery, it's by a specialist who does it under microscopic removal, and he's talking to the pathologist at the same time. And he's taking this dissected piece of your skin out, sending it right to his pathologist who's in the next room. He looks at the edges and he sees if they're clear or if there's more cells for that mole around the edges. If there's more cells around the mole, then the doctor has to go in with a bigger dissection tool and remove this portion of the skin now instead of just where the mole was, and check that edges. If there's still mole cells, then what does he have to do? Cut off bigger. And hopefully there's no mole cells on that far out, right? And then he has to do a skin repair there. Okay, so elevation or diameter of growth. Recent changes is what we're really worried about, though I have to tell you, some people are born with moles, so they don't watch them. They go, oh no, I've had this mole all my life. We had a post office, a postal worker come in. He had this humongous mole right here on his arm. It was asymmetrical, very, very black, but it's never changed according to him in his 40 years. It even always had those hairs on it. Well, my dermatologist insisted that the guy make an appointment and have it removed. So the guy made an appointment the following week and had it removed. And the guy really didn't want to part with it. He's had it all his life. So the doctor only dissected an edge of it for the patient and then sewed it together and sent the edge in. Came back positive for melanoma of the worst kind. And so we had to call this postal worker who wouldn't have had it looked at because he's had it all his life, but it was melanoma. And so he had to come in for a larger area to be dissected. Then he had to have radiation treatment or chemo, whatever it was, and be followed up for that. And he actually thanked us for forcing him to have it dissected. So just because a person's had a mole all their life, it can still need to be removed because it could be harboring melanoma cells. Okay, so psychosocial. Anytime people have bumps or marks on their face, whether it's a hemangioma, which is a bloody looking mole, it's real red looking, or a black mole. My mother's always had a humongous mole right here on her face, and it's always been real thick looking and real, it sticks up about this far from her cheek area, and it's been there since I can remember. And as an adult, she couldn't stand it anymore, and she went and tried to have it dissected, and it grew back almost bigger. So she went in and had the doctor freeze it in hopes that it wouldn't grow back. But psychologically, if you say to her now where there's just bits and pieces of the mole still there because it just wouldn't go away, she hates it and feels like that's the only thing people see on her when you look at her and talk to her. And it's like she's 78 years old and she still thinks that way. Imagine how she thought in those crucial teen years. Could explain why she married such a jerk of my father, but anyway. Psychosocial. Your self-esteem can be down, which also explains why my son married such a bitch, but mean girl. Woo, I've never met such a mean girl. Seriously, that song Mean Girls is not this girl. This girl is meaner than mean. Wow. And then you want to provide consistent information. The best place to get consistent information that most works agree to you going on the website is the American Cancer Society under their skin website. And that way they have this whole little printable picture of moles that are susceptible to becoming melanoma. And it shows them the asymmetrical, the color changes, the unevenness, all of that. It gives them an explanation for it, and it reinstates what you and the doctor are saying to the patient. So it offers more knowledge to the patient, which kind of helps their esteem. Okay, so you always want to provide consistent information. Don't provide the information Grandma told you about when you were young. Okay, we had a nurse that worked in our department, and she told one of the patients that the doctor had given the healing information about keeping the dressing dry, putting the antibiotic ointment on the spot tomorrow, so forth and so on. The nurse came up and said, no, don't use that, only natural. My mama used aloe vera all the time for everything. She has no scars. So this woman went out, looked for aloe vera, and she got some and applied it. And the way she applied it or whatever gave her a very bad infection. She had to come back and have the area opened, drained, to be fixed, and then put on antibiotics. So you cannot give information that your grandma, your auntie, or you always used, okay? Another example is when we get to burns. The Hispanic have a trick for burns. What is it? What do they do when you get burned? Hispanics?
A lot of things.
Huh?
Throw meat on it.
Throw meat on it. Throw mayonnaise on it.
Mustard.
We do the egg.
The only right thing you have in that conversation to help burns is the white part of the eggs. If you can run in the house and get a bunch of white part of eggs and put it on the burn immediately, it does preserve the skin. But who can run to their house and get hold on, I know you're hurting. Let me get these 12 whites out of here. Okay, we talked about herpes simplex. We talked about the herpes hominis, which is the most common herpes sores we get on our lips and such. They are contagious because they're pustulars that have live herpes viruses in them. So as a nurse, if you have a active herpes blister on your lip or anywhere around your lip area, you're not supposed to come to work. But don't pop the blister so that you don't miss hours and come to work, because it has to be completely dry. However, a lot of work status are short-staffed and they want you to work and they're telling you put a Band-Aid on it. It's not safe for you or the patient. You have ill patients. All you need to do is just have one little microorganism from that drop onto the patient. She's got the herpes virus. Okay, the genital herpes, they're pretty much pertaining to the genital area. They have little sores that start off and they erode or get bigger with the blisters and such. The transmission is direct with one of the open lesions, and I just don't get that when it says direct with one of the open lesions. So it means you have to literally find someone who's just got a fresh, wet lesion, and you have to put your mouth all over it. I don't get it, who does that. But we have to say that because why? Because people do it, right? And then the other way that you get the type 2 is primarily sex contact. You can have sex with someone who has genital herpes but no evidence of the blisters yet, and you have the sex with them that night, and a couple weeks later you have herpes. Because the virus is that potent on the skin. It's sitting there in the surface waiting to break out or erode. And you have sex with this person, you don't know them, you met them, they seem like a nice person, and a couple weeks later, maybe even a couple months, you've got herpes. And the doctor will say, did the person have open lesions? No, I mean, I'm a nursing student. I looked, there was nothing there. Well, it doesn't matter. If the person carries it, you can get it. Okay, the simplex, the clinical manifestations, the vesicle at the corner of the mouth, on the lips, or on the nose. It looks like a cold sore. People always say, I have a cold sore, I got a fever, then I got this sore. That's a herpes. It doesn't mean you have herpes. It's just called herpes simplex or herpes omnis. And it means most of the time it's a non-sexual herpes that just is the same virus, but in a different area, okay? So it can cause you to have erythemas, big swelling, bulging, and feel malaise and have pain and aching in your body and a temperature, okay? The second type has various vesicles in the cervix. It can be in the cervix or the penis or all over the genital area. And you can get flu-like symptoms before the outbreak. So you have to really be careful when you're messing around with anybody and everybody. This here is a herpes simplex. It's kind of a really bad case. I've seen it before on people this bad at work when I was the infection control nurse at Kindred. I was also the employee health nurse. I walked out on the floor one day and a nurse had this all over her face, and I said, what are you doing? And she said, I'm working. I can't miss jobs. I have 2 jobs. This is the second. I said, I'm sorry, but you can't be here with that. And she was like, oh, you can't send me home. And I had to get the boss to send her home. She should not have been at work. I wouldn't want to be in public with that. I mean, and she had already worked at the other facility with it, and nobody said anything to her. So of course, when you have herpes and you want to know what it is, we always need the doctor to culture the lesion to tell us that in fact it is herpes hominis or herpes simplex genitalia. And they have pharmacological management. They give you antivirals like a cyclovir. They give you antiviral ointments. They can give you comfort measures. We can tell you to use different creams or different elements to help you feel better. And then patient education. When the blister is wet, people should not come in contact with it. You should avoid contact with anybody while your blisters are wet. Most of the time, herpes blisters are wet for quite a while. Until they're completely crusted over and dry, you should not let anybody come in contact with it. Go ahead and take a 15-minute break. So it's 10 o'clock. We're back in at 10:15. We're going to